So another small crowd tonight, so it's going to be a very personal affair. Any questions anybody has or anything, just feel free to interrupt me. But it's a brain thing again, and I'm Dr. David Henley. The surprise today is that I had advertised there's going to be a talk by Dr. David Spangler tonight on sort of the connection between the mind and the body and some of the illnesses, medical illnesses that affect the brain and psychiatric illness, and vice versa. Unfortunately, Dr. Spangler called me this morning and said he's down with the flu, so he won't be able to join us tonight, and I'll have to postpone that talk and either give it myself later or see if he can give it for us later. Luckily, I happen to have a talk in the pipeline on suicide. I was going to give that in February. It's a good thing I'm not a procrastinator, or else this would have been a disaster tonight. So I had to talk, and I decided I would just practice a couple times during the day today and try to give it to you tonight. And it may be a kind of a timely topic, because I don't know how many of you folks are aware that the FDA just had a meeting recently about antidepressants and suicide, and so we're going to talk about that kind of towards the end. But first, I wanted to kind of give well, the first thing I'll do is give you kind of a real life case example of sort of a sad case, but it tells a story that I think families and practitioners and all of us should be aware of. And so let me go ahead and start off with that. This is a young woman who was feeling suicidal, and the story is that the farmer was driving down a sort of a barren country road. There was nobody else around, and he noticed a truck beside the edge of the road, and a woman that was stumbling off into the field, and she collapsed. And of course, he was scared and didn't know what to do. He called the police, right thing to do. Police came and the ambulance and all, and took her to the emergency room. She had overdosed on antihistamine medications, and the emergency room doctor, when she came to, he interviewed her, and she said, "Well, I'm not suicidal, and I didn't mean to try to kill myself, and I'm, basically kind of minimizing all the things that had happened." Well, luckily, the emergency room doctor was pretty astute and decided, this doesn't sound right. For someone to do that sure sounds kind of serious to me, and she very well could have died. So he put her on a hold against her will. That's something I think we're going to talk about in another session. I'm going to describe that a little bit, but I think psychiatrists get a bad rap for doing this kind of thing, or doctors in general get a bad rap for taking somebody's rights away. But when we're trying to save somebody or protect somebody, that's what we can do. And he did that. So for 72 hours, she was in a psychiatric hospital. And what this does is that it gives us the ability as doctors to observe somebody, to see, are they mentally ill? Do they have some kind of brain illness that needs treatment? And is there something we can do to keep them safe? Obviously, in the hospital, she'd be safer. So the psychiatrist came in over the weekend and saw her each day, and she didn't really look depressed. I mean, she slept well, she ate well, she interacted with the other patients on the unit, she didn't stay in her room in withdrawal, and didn't tell anybody. She basically wouldn't tell anybody what was wrong or what was happening. So that was kind of a worrisome thing. But she also kept saying over and over, "I'm not depressed, I'm not suicidal." So the 72 hours came up, and after 72 hours is up, you have to go in front of a judge and say, yeah, I think this person has a mental illness and they need to be in the hospital and take medicines and treatment. There wasn't the doctor weighed the chances of that happening and for the judge to grant a commitment. And decided, no, she's been here for 3 days now. She's not. Actually, it was more. She was not showing any signs of depression on the unit. She said she wasn't suicidal, and so he released her. Within 2 days, she did the same thing again, and unfortunately, no farmer was there to find her, and she died. So this is an example of even where a professional, a psychiatrist, it shows you how poor we are at predicting who's going to commit suicide. What I want to do tonight is kind of talk a little bit about a few stats about suicide, and then kind of give folks some risk factors of things that they can watch for or see in other people that might lead them to think that somebody is at high risk for suicide. In this case, and I guess a key point here is that we're never 100% perfect at predicting suicide, at predicting who's going to commit suicide. All we can do is, and this is even the professionals, but all we can do is look at how many risk factors somebody has, and the more risk factors they have, the higher risk they are. If somebody has every risk factor we know of, that doesn't mean they're going to be 100%, that's a 100% chance they're going to kill themselves. So I say that, I think, for two reasons. Because I think a lot of times family members who have experienced somebody in the family who's committed suicide, they have a lot of guilt, and they always think, geez, I should have seen that coming, I should have done something else. And, I think the key is even the professionals don't always see it, can't always do something about it. If somebody really wants to kill themselves, they're going to get it done. So I think folks have a lot of guilt, and I wanted to make sure I mentioned that. Now, right off the bat, suicide, how common is it? It's the 8th leading cause of death in the general population of the United States. That's pretty common, and it's the 3rd leading cause of death in adolescence, and that's a little scary. And that's behind accidents, which is number 1, and homicide, which is number 2. Let's go into some of these risk factors now that we know it's kind of a common problem, and we need to go through some risk factors so that folks can identify. First of all, sex is one of the first ones, and these aren't necessarily in any particular order of highest risk to lowest risk. They're just a list of them. But males are more likely to kill themselves than females. It's 4 times more likely than females to kill themselves. And on the other hand, women are 3 times more likely to attempt suicide. Okay? So think about that. So the women attempt it a lot more than the men, but the men get the job done a lot more than the women. Why? One of the things we think that plays into that is the way that they do it. Men, the most common way that a man chooses to kill themselves is through a firearm. 57% of the time men will use a firearm, and of course there's not a lot of chance of surviving that. I mean, if the guy puts a gun to his head, he's probably not going to survive that. Women, on the other hand, 38% of them will use poisoning. They will overdose, and there's a little bit more of a window there for somebody to intervene and save that person's life. So they may not, even though they attempt more, they may not die as often. There's a whole bunch of other reasons too, possibly. Maybe men wait till they're completely suicidal and at wit's end and never seek treatment because of the stigma and everything associated with mental illness or brain illnesses. So there's a lot of reasons it might be, but men, keep in mind, men are the highest risk for, between men and women, are the higher risk for suicide. Age is another one. So the older you are, the higher risk you are for suicide. Why is that? The risk over 65 is the highest risk. And we think it's because there's a lot of stressors in these folks' lives, right? There's a lot of lifestyle changes. They may be widowed. They may have chronic illness that's painful. They may have retired, so they've changed that in their lives. Maybe they're now more dependent on other people. As they get older, they can't drive. They're more isolated. So all of these factors can play in. Incidentally, the older group is also higher risk for murder-suicides, where they take their life of their spouse and then themselves. Somebody who is divorced or widowed or single in older age is a higher risk as well. Race is another one. It tends to be white people, Caucasians, that are higher risk for suicide, at highest risk for suicide. Now that's in the U.S., but there was also a study that included 53 different countries, and they've noted that folks with lighter colored skin had a higher, regardless of age or sex, had a higher risk of suicide than those that had darker colored skin. And in the U.S., the rate of suicide for white people is 12.9 suicides for every 100,000 people. Okay, and it doesn't sound like a lot, but I mean, hopefully these are things we should be able to prevent at some point. The lowest rate is for black folks, and that's 5.3 suicides for every 100,000 people. So there's quite a big range there. These numbers are from 2004. Other folks that have high rates, and the American Indian people and Alaska natives are 12.4 per 100,000. It's almost as much as whites, so they're pretty high as well. But on the other hand, the Hispanics and Asian and Pacific Islanders have lower rates down around where African American folks are. Geography is another risk. For some reason, the western states and then Vermont. I don't know why that is exactly. But in the U.S., that's what the rates show. Rural areas have a higher risk than urban areas. Now, I don't know why that is. I've thought about that. It may be isolation, maybe. It could be poverty, maybe a little more. I don't know.